Okay, so let's get started. So acute kidney injury, it's really important for exams. It's a very common topic, but it's also important in real life because 18% of inpatients develop AKI, and in ICU, 50% of patients develop AKI, and it can have a mortality up to 25%. So it's a really important topic to know. So what is the definition? AKI is an acute decline in kidney function. So it's different to chronic kidney injury because obviously it's more acute. You measure the serum creatinine, and if it's greater than 26 within 48 hours, or there's a rise by 1.5 times the baseline within 7 days, or a urine output of less than 0.5 milliliters per kilogram per hour for 6 hours, that is AKI. So there's different stages of AKI. AKI stage 1 is basically what the definition was on the previous slide. And then you can see it gets progressively worse with AKI stage 2 and stage 3. It's important to know the stages because it tells you the severity and therefore how aggressively you need to treat it. You stage it based on the most severe criteria. So for example, if the creatinine was really bad, but the urine output wasn't that bad, you'd base it on the creatinine. So for example, if the creatinine was greater than 353.6, but the urine output wasn't that bad, then it would be stage 3 AKI. So you go off the most severe criteria of that. Okay. So the causes. Oh no, the risk factors. So age is a risk factor. As you get older, you're more likely to develop it. Nephrotoxic drugs cause AKI, and we'll go on to some of those particular drugs. If you're male, you're more likely to get it. If you've got diabetes, you're also more likely to get it. If you've got CKD already, you're at an increased risk. If you've had surgery, generally because they're nil by mouth, they're dehydrated, so there's less perfusion to the kidneys, things like that, usually a multitude of things. Volume depletion, such as dehydration, and multiple myeloma. So we'll go on to a case now. Okay, so this is a 65-year-old man with diabetes, dyslipidemia, and CKD. He presents feeling generally unwell. He's recently been unwell with a lower respiratory tract infection, during which he wasn't eating and drinking much, but he's since recovered from this. His medications are simvastatin, pramipirole, naproxen, and glycoside. On his bloods, he's found to have a creatinine of 360 and a urine output of 300 milliliters over the last 12 hours, and he weighs 60 kilograms. So, does anyone know what stage of AKI he's in? If you can just pop that in there. Oh, just said I'm unmuted. Hope you've been able to hear me this whole time. So if you can just tell me what stage of AKI you think that might be. Yeah, well done. So that is stage 3 AKI. Because you, as I said before, you go off the most severe criteria, and here his creatinine fits criteria of AKI stage 3, even though his urine output actually doesn't. I think it fits stage 2, but you go off the most severe criteria, so therefore it's stage 3. So looking at his history, what would you say the most likely causes of his AKI are? Pop it in the chat again. Yep, so as people seem to be saying, some of his drugs, namely ramipril and naproxen, are causes, and then also the fact that he's not been eating and drinking, because this means he's been dehydrated and therefore not perfusing his kidneys as well. Okay, so well done. So going on from that, we're going to have a look at the causes of AKI. Okay. So I use a mnemonic to remember the basic causes of AKI. Obviously, this is very basic, but it's a good mnemonic to help remember in, OSCEs where it's like a prompt if you're feeling stressed and you can't really think of anything. So sepsis and hypoperfusion, toxicity, by which I mean drugs, obstruction, and parenchymal disease, such as glomerulonephritis. So these are just the very general causes, and we'll go into the causes in a bit more detail on the next few slides. But just having a look at the drugs, there's another mnemonic which I use to remember it, which is CANDA. So the drugs that can cause AKI are contrast, ACE and ARBs, NSAIDs, diuretics, and aminoglycosides. And then some extra ones at the bottom is chemotherapy, cyclosporin, and tacrolimus. So these drugs are common things that would come up in finals exams as causes for AKI, and also the prescribing safety exam if you have to sit that. Okay, so just a bit more detail about the causes. The causes can be split up into prerenal, intrarenal, and postrenal. The most common cause is a prerenal causes. I think they make up about 60% of AKIs, and prerenal is due to a decreased renal perfusion. So within this, the causes can be a decreased vascular volume, such as diarrhea and vomiting, hemorrhage, and pancreatitis, diuretics, heart failure, hepatorenal syndrome, and liver failure. There's also hypotension caused by cardiogenic shock, septic shock, and anaphylactic shock. And that's because your vessels are vasodilated and therefore you get lower blood pressure. As well as this, renal artery stenosis, which means that there's less blood getting to the kidneys, and drugs, which I already mentioned, NSAIDs and ACE and ARBs. So the reason NSAIDs cause prerenal AKI is kind of demonstrated in that diagram, but they cause constriction of the afferent arteriole, which leads to decreased perfusion and therefore decreased GFR. And then ACEs inhibit angiotensin II mediated vasoconstriction of the efferent arteriole, which means that the efferent arteriole becomes more dilated, and therefore there's less pressure in the glomerulus, which means that there's again decreased GFR. Oh, and one other thing, ACE and ARB should be avoided in bilateral renal artery stenosis. Okay, so moving on to the next type of AKI is intrarenal causes. So this means direct damage to the kidneys. So this can be glomerulonephritis, acute tubular necrosis. Acute tubular necrosis is usually progressed from prerenal AKI, as there's prolonged hypoperfusion, which leads to damage and ischemia of the tubules, but it can also be caused by drugs as well. As well as this, things that affect the vessels, such as vasculitis, hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, and disseminated intravascular coagulation. That was a mouthful. Okay, and then another cause is acute interstitial nephritis, which is basically acute inflammation, which can be, again, caused by drugs or prolonged hypoperfusion. And then other causes such as infection and sarcoid. And then the third and final type of AKI is postrenal causes. And this is due to obstruction anywhere in the urinary tract after the kidney, so between the renal pelvis and the urethra. This means that if there's an obstruction, urine then gets blocked back up and then damages the kidney. Okay, so some of these causes can be within the renal tract, such as renal stones, tumours, strictures, clots, and iatrogenic injury. So, namely catheters for the iatrogenic injuries. As well as this, something can be pressing on the outside of the renal tract, pressing inwards and causing a blockage. This can include BPH tumours, such as prostate tumours, and retroperitoneal fibrosis. Also, a neurogenic bladder, which could be due to MS or spinal cord lesions or peripheral neuropathy, which basically means that your bladder doesn't contract and squeeze out the urine. Okay, so what investigations would be done for AKI? Firstly, urinalysis. Things such as blood and protein or casts in the urine would probably suggest an intrarenal pathology, such as glomerulonephritis. You'd also want to do a set of bloods, looking for various things. FBC looks for infection, anemia, and platelets. These can all be suggestive of the various causes of AKI. Obviously, you want to do U&Es because to diagnose AKI, you need to have the creatinine. And then you also want to look at the electrolytes, especially the potassium, because one complication of AKI is hyperkalemia. You also want to look at the bone profile, as well as the LFTs. LFTs, again, can show you some of the causes, such as hepatorenal syndrome, clotting, because, as I said previously, DIC can be another cause. Lactate will, if that's raised, could be suggestive of sepsis. Creatinine kinase could show rhabdomyolysis, which is another cause of AKI, and CRP could show infection or vasculitis. And then some other investigations you might do is a blood gas, looking for acidosis, which is a complication of AKI, ECG showing hyperkalemia, MSU, blood cultures, hepatitis B and C and HIV, as well as a chest X-ray showing pulmonary edema, which is another complication of AKI, and various other causes. Okay, so those previous ones I mentioned were more of the main investigation, but depending on what you think might be the cause, you might order some extra investigations. So if you're thinking it's an intrinsic cause, you may want to look at the immunology. These various blood tests and things show might be raised in things like glomerulonephritis. Obviously, if you're thinking it could be myeloma, you'd want to do a myeloma screen, which looks at immunoglobulins, bent strain proteins, electrophoresis, free light chains, skeletal survey. In a skeletal survey, you might see things such as a pepper pot score. And then also, if you're thinking it's an intrarenal cause, you might do a renal biopsy. Again, that might show you things like glomerulonephritis. If you think it could be an extrinsic cause, you probably want to order a renal ultrasound scan, because that will show you things such as masses that could be within the renal tract or things compressing it from the outside, such as tumours or stones, or strictures. So the management of AKI. Firstly, you want to stop any drugs that could be the cause. Then you want to assess the volume status. If they're hypovolemic, you want to give a fluid bolus. This would be something like sodium chloride 0.9% over less than 15 minutes. And you'd carry that on until they're euvolemic or they've had 2 litres, and by that point you need specialist input or senior input. If they're euvolemic, you just want to give them maintenance fluids, keep them hydrated so that their AKI doesn't worsen until you can find out what the cause is. If they're hypervolemic, for example, in heart failure, you might need diuretics to get off some of that fluid, or you might also need renal replacement therapy. Obviously, you want to monitor the fluids, and to do this, you need to monitor the input as well as the output. And to measure the output, you might need a catheter. Again, along the same lines, you want to measure the daily weights to monitor the fluid. The main treatment, obviously, is to treat the cause, and there are a lot of causes, as I've said. So the treatment does vary along with the cause. If it's a post-renal cause, you want to catheterize them because that's going to relieve the obstruction, or if the obstruction's further up, they might need a nephrostomy to relieve that obstruction. Okay. So some indications for referral. You don't always refer. Sometimes you can manage them on, whichever ward you're on, or in A&E or wherever. But for certain things, you do need to refer them. So if there's any indications for dialysis, which we will come on to the indications a bit later, if you don't know the cause of the AKI, if it's an intrinsic cause, or if they're AKI stage 3, they need referring or at least discussing with nephrology. If it's a post-renal cause, you're going to refer them to urology. Okay, so next we're going to come on to the complications of AKI. Actually, first, does anyone have any questions about the previous part? Do you want to just pop them in the chat? Any questions so far?
I believe somebody asked, are all contrasts nephrotoxic?
I don't know. The one that I know about is the iodine contrast. And I know that if you're planning to give that to someone and you think that they've got risk factors for AKI, you'd give them fluids first just to, really maintain their kidney function, and then you'd give them contrast afterwards, and then you'd give them more fluids following that to try and avoid AKI. To be honest, I don't know about the particular types of contrast. The main one I know about is the iodine-based contrast.
Perfect. Thank you.
Okay. Is that it? Okay, fine. So we'll move on to the complications of AKI. Now, the complications are basically the same as the indications for dialysis. I remember these complications by the sort of mnemonic AEIOU. So can anyone have a guess of what the complications of AKI are? Pop it in the chat. Yeah. Yep, so you guys seem to know a lot of this already. But so the A stands for acidosis. So this would be, it has to be a severe acidosis that isn't getting better if it's an indication for dialysis. So this would be a pH of less than 7.2 or a bicarb of less than 10. The E stands for electrolyte abnormalities. The indication for dialysis would be a refractory hyperkalemia. So you've treated it and it's still not getting better. The I stands for intoxication. So if they've overdosed on certain drugs, you need dialysis to sort this out. Otherwise, it's not going to get better. Some of these drugs include lithium, isopropanol, methanol, and ethylene glycol. Okay. And then the O stands for edema, which is pulmonary edema. And again, for someone who's being treated for this but it's not getting better, that's an indication for dialysis. And then the U stands for symptomatic uremia. So that's things such as pericarditis or uremic encephalopathy. Okay, so that's an important thing that could come up in exams. So AEIOU. Okay, so this is a case. A 78-year-old male inpatient has been diagnosed with AKI stage 3. An ECG is carried out and it shows this. So can anyone tell me what's on the ECG? And then following that, can anyone tell me the complication of AKI this man has? Okay, so on this ECG, there's really big T waves, as someone mentioned. You also get flat P waves, as well as a long PR. There's also a wide QRS, as you can see, especially, well, all over pretty much, but especially in like V1, V2, V3. You can also get AV blocks and something called a sine wave, which is starting to form in lead 1 here. If I just gave away the answer, but if this progresses, then you can also get asystole, pulseless electrical activity, and VF as well. So all these things on an ECG point to hyperkalemia, which, as we said, is a complication of AKI. So what is the treatment of hyperkalemia? So you're going to treat it if potassium is greater than 6.5, or if there's ECG changes. And if you see those ECG changes that were on that previous slide, you're going to be worried, because that is verging on the cusp of arrest. So the treatment of a hyperkalemia is 10% calcium chloride IV over 10 minutes and 10 milliliters. So the way I remember this is 10, 10, 10. So the calcium chloride doesn't actually decrease the potassium itself. It just protects the heart, so it's cardioprotective, and it's trying to prevent them from, arresting or really bad arrhythmias. Whereas the insulin and salbutamol do actually decrease the potassium, because they drive potassium into the cells and therefore decrease the amount of potassium that's in the blood. So you want to give 10 units of insulin along with glucose over 15 minutes, as well as salbutamol nebs. Obviously, on top of that, as well as treating the high potassium, you want to treat the cause so that it doesn't keep happening. Okay. So another case. We've got an 82-year-old lady who's recently been diagnosed with AKI stage 2. She's become short of breath, and so a chest X-ray is carried out. So, can anyone tell me what complication of AKI this chest X-ray shows? And then after that, how is this complication treated? Okay, so there's people saying quite a few different things. So the chest X-ray has bilateral perihilar shadowing, which is also called a bat wing. This is this sort of fuzziness in both the lung fields around the sort of center and lower bits of the lobes. So this is pulmonary edema. With pulmonary edema as well, you can get blunt costophrenic angles, which means the little angle between the diaphragm and the chest wall. You can also get fluid in the fissures as well as curly B lines. However, I've never seen curly B lines, and you know they're just something that you kind of say in exams, but you never really see. Okay, so let's go on to how this is treated. As someone said, diuretics. But first of all, you want to stop any IV fluid because you don't want to keep overloading them when they're already overloaded. You're going to sit them up because this helps them breathe, and you're going to give them oxygen. You're also going to have a strict input and output of fluid, and you're going to give them IV freeze-dried to try and get some of that fluid off. As well as this, you can give them IV nitrates. And if it's really bad and it's not getting better and they're desaturating, you can consider CPAP. And then obviously, as I said before, if it's refractory and then not getting better, you can consider dialysis. Okay, so that's the main part of the lecture done. There's just a couple of questions now to round it up. So, which of the following drugs does not cause AKI? Pop it in the chat again. Okay, so as a few of you have said, the answer is metformin. So if you think back to the mnemonic that I said earlier for the drugs that cause AKI, that was Canda. So that's C, contrast, A, ACE and ARBs. Lisinopril is an ACE inhibitor, so therefore that does cause AKI. Then we've got NSAIDs such as naproxen or ibuprofen. D, diuretics, therefore furosemide does cause AKI. I know a few of you are saying that in the chat. And then A is aminoglycosides such as gentamicin. So the only one that doesn't contribute to AKI is metformin. There's sometimes some confusion because during AKI or renal impairment, you probably should stop metformin because it can cause lactic acidosis. However, this is because of the AKI, not because it's actually causing the AKI. It just, you don't want to cause any problems when you've got a low renal function. So, next question. Which is the most common cause of AKI out of these three? Yep, so loads of you are saying in the chat dehydration, and that is correct. So as I said before, prerenal causes are the most common cause of AKI, contributing to about 60% of the causes, and within that, dehydration is a very common cause of that, especially in elderly patients or people who are just generally ill and haven't been eating or drinking, or if they've had surgery and been nil by mouth. So yeah, dehydration is a big one. Glomerulonephritis, even though it's something that comes up in exams and things like that, it's not actually that common. And then ureteric strictures, again, not the most common cause. Okay, so that is actually the end of the lecture. That was a lot quicker than I thought it'd be. But if anyone has any questions, do you want to put them in the chat now, and I'll try and give a go at answering them.